All righty, here we go. Uh, we'll give it just a minute or two, let everyone kind of filter in from the waiting room, let the webinar get kicked off. So some general housekeeping as we kick off this webinar. I'll make a nice little intro, but I'm not going to necessarily introduce you wonderful people on this call. So we'll go around and I'll let you guys introduce yourselves. I think that your backgrounds and your titles now are so key to why we're doing this. So I'm really going to rely on you guys for this one. But yeah, I appreciate everyone for taking their Tuesday afternoon to hop on with us and to do this. I think the challenges we all face, right, are universal. All right, healthcare is healthcare. We all know that there's a broken system. We're putting band-aids on things. Whatever you want to call it, we all have a way to kind of give ourselves that easy button. If anybody remembers those commercials, I think it was Staples back in the day, right? Like the big red easy button, make my life better. So just to kind of frame out today's topic and what we're doing, we're talking about restrictive payer policies and step edits. And the group we have assembled today, if I'm allowed to say I can assemble the Avengers, because I kind of feel like we have here. As you might have seen the announcements, you may have seen the promotion, we do have some different faces on with us today because everyone who participates in these events has patients first and things come up, right? We have to be flexible, we have to adapt. And so while Lori and Mark are unable to be with us today, they're in their clinics and they're working hard and we appreciate them for what they do. So I have some subs in and I'm thrilled that they are here. So just a little bit of a point of view so that everyone is aware of what's going on for today's webinar. We're not here to make any payers mad. We're not here to call anybody out and saying that there's a problem, right? We just want to talk about how we understand policies exist. We understand that everyone has their own line of thinking. However, with our patients first in mind, here's what we do to access and to treat our patients. So first and foremost, I am extremely thankful to our sponsors for this webinar, Daiichi Sankyo and Prescribe Plus. Without your partnerships and support, we would not be where we are today and able to do one of these. So without further ado, Geraldine, I will let you kick this off. If you could please introduce yourself.
Sure. My name is Geraldine Arneson. I am a pharmacy manager at Jefferson Healthcare. I'm a board certified oncology pharmacist, and I have a lot of experience in the infusion centers.
Excellent. Melanie?
Hi, I'm Melanie Woodland. I'm the manager for pharmacy access and reimbursement at St. Alphonsus Health System based out of Boise, Idaho, and I'm the manager for specialty drug, hospital-based drug financial navigators.
Jordan Johnson, Chief Innovation Officer at OncoSpark. Been involved clinically and administratively on health policy, both on the infusion medical oncology and radiation oncology side for the past 6 years. So happy to be here.
Angie, all you.
Hi, my name is Angie Santiago. I am the Oncology Financial Advocacy Manager with the Sidney Kimmel Cancer Center at Jefferson Health. We're located in Pennsylvania and New Jersey.
And Linda.
Hi, I'm Linda Morris. I'm a medication authorization technician with the University of Virginia Health System, specifically the specialty pharmacy. And I deal mostly with clinic-based work with authorizations, appeals, things like that.
Great. And I didn't introduce myself. I'm Elizabeth Johnson. I'm the president of NMAPA. Sorry about that. So again, thank you to our sponsors. Thanks for all of you guys for being here today. I kind of want to kick things off with, we throw out these buzzwords and these key terms and restrictive payer policies, kind of self-explanatory, but for those that may be newer to this space or here to learn today, step edits. Linda, can you kind of fill us in on what those are and from your perspective?
Linda, you may be on mute. So we're never going to get over that out of the Zoom era, being able to say
I did a t-shirt with it. Yeah. Linda, sorry, go ahead.
I got it. Step edits are pretty much drug therapy categories that insurance companies want you to do before they give you a paid claim. I work with MS. A lot of frontline therapy or first line therapies are injectables like Avonex, Betaseron, Platigrade, and Copaxone. They're your first line therapies. Then orals like Tecfidera, Aubagio, Mavenclad, things like that are second. And then finally, they'll go to infusions. And what they want you to do is do the injections first. Then they'll ask, have they done the orals before they allow you to go to infusions? That's the main step edits.
And generally, these are low-cost drug option. I mean, pathways that they prefer. Obviously, if people aren't familiar, that's the progression they would like to see is exhaust the lower cost options first and then progress on through.
Right.
Yeah.
The injections being out the longest, they prefer those first.
Correct.
The orals more expensive, more convenient because they don't have to inject themselves. And then the infusions, which require so much extra work, they really don't like to do those unless they've had those first line therapies.
So I always like to ask, right? So when I pull up a policy and I'm reading through it and I see that there are edits or there's something going on, right? It kind of evokes a sense of like, oh no, or sometimes it's frustration if it's been a day. Melanie, I know in your space, you come across this quite a bit. Any thoughts? What's your first reaction when you're like, oh, I got to do this?
So that's actually my team, their first reaction. It's frustration and kind of, what do I do now? And they usually reach out to me and I usually will tell them, well, let's read it, pull up the policy. Have you pulled up their policy that it's referencing, right? And read what is required? And a lot of times we will work through those steps, right? I don't know if you want to go into right now, like what are the ways we work through this, but they usually will kind of deer in the headlights and think, well, I'm gonna have to tell the doctor we just can't give this, or it's not going to be authorized. So it does kind of stop them in their tracks, but
I
they
think
usually kind of need a little support to work through it.
Yeah, I mean, I think oftentimes, Melanie, to your point, the doctor has a care path that he or she has chosen and what's best for the patient in their mind. And they are not going to keep up with all of these policies, all the changes. It's constant moving goalposts. They're not going to keep up with it. So really for people inside the department that know what's going on, it's their job. And you do have to be somewhat aggressive in nature to be able to let them know, these are some of the barriers that have been put in place for this patient. And this is how it could impact their care path, the timeliness of their care path. And you got to have somebody that can communicate that quickly and kind of put all the pieces together for them. So I think it's oftentimes, I think when you see something that, Angie, I'm very familiar with your department and what goes on up there, and it looks like a well-oiled machine on the outside, but people have no clue what's going on behind the scenes to make it that way. It's a lot of work.
Geraldine, you're muted and you got to put your hand back down. See?
I think the same as Melanie. I think it's not intuitive to go to read the policy. A lot of times what happens is the therapy just stops right there once the payer says no. If they don't outright say, come back and say you have to choose this instead, it just gets kicked back to the provider as we can't fill this. And then it's put back on the provider to decide where to go next. And so it does extend out the time to treatment because the provider is playing a guessing game. And then they're going to select another treatment that's not according to the policy. So I think it's important. And I really like, what is it? Policy Viewer, Policy Reporter. Where you can go and search for all these peer policies and pull them and literally read them, from beginning to end. And then after you get used to, using those same products, you're going to end up memorizing them and being a great resource.
So I'll tag on and I'm going to pass it to Angie. I think that to kind of explain some of our backgrounds here. So I'm a nurse in a clinic, right? That's where I started. Then I would triage over to, Melanie, Angie, Linda, you guys. Jordan, you have, admin background, and then, Geraldine, you being a pharmacist, right? Like we all have a key component in this. But Angie, I'm gonna kick it to you because as soon as I memorize something, it changes. So what about you?
Yeah, I think that's part of the hardship, right? So there's so many different payers for us, and so many different payers want different drugs that they consider their preferred drug or what they want the patients to sort of fail on first. And then what sort of makes it hard, I'm just throwing it out there for, I know our authorization team, we have a lot of new members of the team, right? And so they're trying to stay on board of everything. And then when you have a payer that says no authorization required, and it could be like pre-meds for chemo, right? So we think, oh, pre-meds, what policy am I really looking up for pre-meds? Like, they have nausea. It makes sense to give them that. They're about to get chemotherapy. And then it goes back to Geraldine said, like, to have to go to each payer policy to say, okay, you're allowed this one first. You're okay, but no, you want Zofran to fail first before you allow Aloxi. I think it just leads to more confusion. And especially if it's saying no authorization required, because then what happens? That person might approve it, not realizing it. And then on the back end, we get the denial and everyone's just confused. So it's like so many steps for this role because of these step edits. I think just makes it harder for everybody.
Does anybody ever go back to the prescribing insert or the PI of these medications to pull anything to compare to these policies? Geraldine?
I'm going to have something to say for everything. So, yes. So actually, at least I would say in the infusion space, for most commercial payers, they're going to pay for what's FDA indicated. So you can find the FDA indication in the package insert. You can also find it in other drug literature as well. For oncology, they'll pay for things that are outside of what's FDA indicated, but you have to go to NCCN Compendia or something like that. For Medicare, those are the ones typically don't require prior authorization on the front end. This is for infusion, so this is medical benefits, not pharmacy benefits, but they don't require prior authorization. But like Angie was saying, you might think, oh, no prior auth, okay, I can give all of these things and Medicare is going to pay for everything. But in reality, that denial is going to hit you on the back end. So you're not going to receive payment for it. So you still, for no prior auth needed, you still need to be, it's probably even more important to be informed on payer policies for those patients.
Yeah, one thing I'll add, if it's okay. So if you currently are signed up for United Healthcare as a provider portal, they actually give the NCCN compendium 1 year free for you. So that's a good
Nice.
tool to have. And then the other thing is just that, definitely the policies, we recently had a whole Lupron issue because Lupron is okay for breast cancer, 3.75 milligrams. But one of our payers was like, up 3.75. Nope, not for oncology needs, only for non-oncology needs. And so if you're a big institute like we are, you might not be seeing your AR in a timely manner, right? So those trends of denials might not come to you until 3, 4, 5 months later sometimes. And now it's like, okay, you have to go recap. Okay, what patients did we allow to get this treatment? Now we have to figure out. So, those payer policies definitely play a key part. Green does not mean go, and it says authorization not required. If anything, it means more research needed.
Right.
And I think just to add there, I mean, a lot of times we look at the payer policies and stuff, but for oncology, for some of the infusion things like that, I mean, we have the UMs, right? Oftentimes people forget about the utilization management companies. So Evacor, New Century Health, and their policies are really, really changing. We've been told that Evacor, some of their big contracts and people that they oversee is now going to go to New Century Health. So we expect some of those guidelines to change. And how do you keep up with all that? So not only do you have your payers and what they're doing in policy, you have Medicare, which is our NCDs, LCDs. Now we have the utilization management companies. And how do you track that into Angie's comment? A patient's always at a different level of their step therapy or process, and how do you keep up with what's their payer, what's the guideline, where are they? And that's the biggest thing to me, is how do you keep it all structured and organized?
And I think, I'm going to kind of toss this Linda's way and Melanie's way. So a lot of times in these policies, we're seeing you have to have this and this, or this and one of these. what do you do in those situations, right? I know for me, it's yelling at my providers if I need something, but Linda, Melanie, either one?
For my team, that's usually one of the first things I have them do before we move on to the other steps. And it is, okay, let's read the policy and see exactly what criteria do they have? What are they expecting? You know, and read it all the way through, because usually you go down further and it will tell you at some point on a lot of them, you know, exceptions to this. If the patient has any of these reasons, right, then it is okay. If their labs are a certain level, if they have any comorbidities, if there's, or even just an explanation, you know, like exceptions can be approved as needed. So it's telling them, right, read it all, find out exactly what it is that they are looking for, their requirements. And then before we usually bug our doctors, because we're working with so many of them and some of them react a little different, it's go look through the records now, because normally we send the most recent progress notes for drugs if there is an auth needed, right? The same thing as Angie said, if no auth is needed, then we're just doing this anyways to make sure, checking policies that it is medically necessary, it's gonna be paid, that is their responsibility. So they need to know that. But then we will go through the records, and a lot of times you can find like, oh, they're required to have tried this as an oral first, or have tried this as an injectable first. You might have to look back in the records, but there is a note from 8 months ago that says they did try and fail it, or they tried to take this oral and they couldn't keep it down. So, you know, we are moving to this. Or sometimes in the policy, maybe not for that specific drug, but just that payer's policy in general is, if, you know, there may be an exception that, well, they have had this drug before though. Maybe they took this drug before, they switched to another drug and they're back on this one, you know, and sometimes there's an exception. If they have had this drug and it was successful within the last year, then there can be an exception for them. And I could go on about all the different types of exceptions that you could look for, but you want to go and read the records first, right? Because sometimes it's not even your own chart notes. It might be from a referring provider, from their primary care doctor, and it's scanned into your external records, and you just need to go review the records and see if they might actually need it, and you just, you know, you don't know that yet. So we try to do all that before we go to the providers.
Certainly. Linda, anything on that? I know Geraldine's chomping at the bit over there. I see the hand.
Yeah, I see.
Always.
I pretty much do the same thing. I think my main thing is I kind of read through what is necessary for the approvals, or I pinpoint things that might cause me to maybe they word these questions sometimes where you're just like, what? So when you get to that question, you have to reread it a couple of times. And when you finally get what you're looking for, I do go through the medical charts. I like it when doctors are very efficient with their notes, and sometimes they aren't. Delineating care from like start to finish is really important, like knowing your patients. And since I'm in a clinic that does like one specific disease category, you learn your patients. So knowing your patients is important to me. What else do I do? I'm not afraid to call them and do a verbal auth, because sometimes you can get on the phone with someone and it's completely different than doing a form or going online and doing it, because you've got someone on the phone and you'll be like, hold on, can you repeat that? Can you get someone else for me? I think we need to go a different route.
Yeah, that on the phone is helpful. Sometimes I just need to, you know, really get down to brass tacks, and that's the way I like to do it. Geraldine, what you got?
Okay, mine's a two-parter. I apologize up front. Okay. First of all, one thing dislike about Aetna is that their pre-certification paperwork has the step edits built into it. And there are going to be pharmacists across the United States that disagree with me on this, but I feel like pharmacists are best positioned to fill out this pre-certification paperwork, because it's going to land to someone who's non-clinical. If it's the prior auth staff, you know, there's a high turnover rate with the prior auth staff. They're not clinical. They do the best they can to dig through the notes and try to answer the questions, or if it's from an outside referring provider, they'll kick it back to that office. And then perhaps a medical assistant is going to fill out that paperwork. And literally all it takes is one checkbox incorrect, and that treatment is going to be denied. So, like my favorite is for Procrit. Is it going to decrease? Will it decrease the number of transfusions by 50% over the next 6 months? I don't know who can predict something like that, but if you don't check yes to that box, that Procrit is going to be denied. Now, so that's what I mean. Like there are these so detail oriented pre-certification paperworks. And so I have found with my team that having pharmacists do those, we have a higher rate of approvals. The second thing is somebody asked about site of care denials. So the site of care denials, I do screen for those. I kind of know the drugs that are going to be pushed out. So just for everybody's information, site of care denials is the hospital is the most expensive place to have an infusion administered. The administration fees are the highest, the markup on the drug is the highest, then it goes to the physician's office is the next highest, then the standalone infusion centers would be the lowest, and then home infusion is the least expensive. So there are lots of things where if there's not going to be an anticipated high rate of infusion related reactions, they are going to try to push those drugs out at least to the physician office level to cut down on the administration fees and drug charge. Ultimately, it does save the patient money, especially if they have a high deductible health plan. You typically don't see this with Medicare, but you do see it with a lot of commercial payers. And I would say United and Blue Cross Blue Shield are probably our highest number of site of care denials that we have to work with. Okay, I'll be quiet.
Can I add?
Yeah, I was gonna say, who's
Angie,
next on that
listen,
one?
Add.
Listen, Angie's fixing to add something. I feel it. Come on, Angie.
So I saw the question about what did it say? Same thing about site of service, but when it's office-based infusion center and whatnot. We deal with the whole site of service big time with IBC for us, Independence Blue Cross, and the injections. We actually had to carve out space in our infusion center to be considered professional billing space. But issues still happen, authorization issues still happen type of thing. I think for me personally, I sit here and I feel frustrated because I can't understand why the hospitals just don't go back to these payers that want site of service and say, you know what, fine, this is the most you're going to pay us. This is our new contracted rate. To have to go back and forth and have a patient walk over to get their injection from where they got their treatment just seems silly. I'm not a big fan of it, but it's definitely a hardship for just the whole process between the doctors and whatnot. I just wanted to add one thing to what Geraldine said. When you're not fortunate to have pharmacy, and I agree 100%, pharmacists probably would be the easiest ones to fill these forms out. I think it really goes back to educating your doctors, right? Meaning that, for us with our iron therapies, right? If you want the easier route for our patients to, get like for instance, the Injectafers versus the Venafers, where it's 8 treatments, put that in the note to make it make sense why the payer would approve that. Whether it's because of, the hardship that the patient can't come in once a week for the next 8 weeks, or that they did truly fail. I think, it's an education to the doctors as well, because like you said, you have non-clinical people attempting these authorizations. So if you don't want it prolonged, if you don't want constant back and forth, we really need to educate our doctors to put what we need in those notes so that it can be a little bit more of a seamless process.
Yeah, absolutely. So one of the things that, obviously I think people come to these webinars, right? And they listen in because everyone's looking for, we go back to that easy button, right? We want to know what works for you guys and what doesn't. But before we get into what you've done in your facilities, there's so many great tools and resources out there provided by manufacturers. Angie, I'm going to kind of call on you to kind of talk about these because you and I've had discussions around this before, and then kind of go into how you utilize those in your facility. I'd love to know.
Yeah, I think the majority of the manufacturers, you have to build relationships with your field reimbursement managers, right? So for us, I have an open door policy, not a stop in, drop in whenever you want to, but email me the day before, you can stop in, open door policy with my field reimbursement managers. Why? Because they're bringing those type of documentation so that you understand the new indications for the drugs, but also when you hit these step edits, when you hit the bump in the road where the payer might be denying it, where they're giving you tons of resources on appeal letters that you can use, as well as like, different information. So, I know today we are partnered with Daiichi. And so even with Daiichi, they, Catherine's my field reimbursement manager, and she drops me off a tool. And what this is actually a key operational consideration for payer policy exceptions. So this is what we can go back to our doctors and our authorization team to say, okay, when we see that the step edit might not have been met for the iron, here are your choices. If you do this, this is how we're going to get your first line that you prefer, hopefully approved. So, I just think it goes back to keeping your relationship with your field reimbursement manager, as well as educating your doctors, right? You can't, completely go against Aetna in a sense of, if they are clear on their policy, say this is a step edit, and you're just completely bypassing it, but you're not even bypassing it to tell the payer why. So, that's why it's so important for the doctor to know that documentation needs to be in there.
And Angie, can you repeat what that piece of
Oh,
paper was, what tool you have?
Oh, sure. So this one is, it's called Key Operational Considerations for Payer Policy Exceptions, and this is for iron therapy. So this is really helpful for us for, when our doctors want to not go through 8 weeks of making your patient come in for Venofer.
I need a copy of that. Geraldine, what you got? I see that hand up.
I just make the distinction that the field reimbursement managers are not the same as sales reps. So the field reimbursement managers, it's a role that, I was so happy to find out about in 2016 or so. They bring, they are able to help out with your patients and getting things approved and helping you write these letters as well. But they also bring a lot of the most current clinical information to you. And so there are times when the payer policies are actually not updated to have the most clinical, the latest clinical information in them. Even Medicare LCDs don't, sometimes have the most recent clinical information. Infliximab is a really great example of that. They don't reference infliximab levels or antibodies or anything like that when it comes to approving certain dosages of infliximab. So when you appeal things, your appeal letters need to have the most up-to-date clinical information, and that will help you when you're trying to get something approved either on the front end or the back end.
Certainly. Melanie, Linda?
It's Angie. I, on my cell phone, I could pull up most field reimbursement managers that, for most of the big manufacturers that I keep in touch with a lot. A lot of times I will tell them too, if you have additional education material or billing and reimbursement guides that have come out when there's a new indication, a lot of times they will stop by and actually go clean out their old resources, because we have it all organized by manufacturer for the drugs, and they will put in the new ones because we are usually in a hurry and want to go there and look and see what resources are available. And they will actually come, especially if I have new members on my team, or it's just once a year, or if there is a specific topic that comes out, and they will usually come in person and train my team. And I encourage it a lot of times, if there is a new indication, or if I have a group of new people, I really ask them to come out and they will do the education, because I think that is, like Angie was saying too, we don't ask our pharmacists ever for help. Usually we work hand in hand with them, but my expectation of my team is to understand it. You have to be invested in this and know that it's going to be like ongoing education with this. And a lot of that, it helps to have people that represent some of the most used drugs that we have come out and start just that, the education, hearing the name of the drugs. Here's all the approved indications for this drug. Here's things to keep in mind, certain tests that you need before giving this drug. And here's all these things, right, that we learned. And it just helps with that repetition, getting it in their head and understanding. And then they will start to bring up things like NCCN guidelines. And, so when we go into that training on NCCN guidelines, we're also, it's just the repetition, it starts to stick in their minds. So we love that. And just like that tool that Angie showed, a lot of times from manufacturers comes the best education for a lot of things when it comes to Medicare savings programs. I mean, they usually invest a lot of resources and put together this well-made resource on a very complex topic. And so I tell all of them, like, if you ever come out with a topic, right, based on any of these things, share it with us, please. And they're usually emailing us. They email our shared inbox to all the navigators on updates also, like Medicare Advantage plans or this major payer. This is a new process that they're implementing starting in January, a new requirement that's going to apply to all hospital-based drugs. So they keep us up to date on a lot of things.
No, and I was going to say, I think that's important. So on the drug side, we don't see this. It's completely the opposite on the procedure side. So what we don't want to see on the procedure side is we don't like to take any advice from vendors when it comes to billing, coding, and compliance, because there's a conflict of interest there. That's the beauty on the pharma side, is there's no conflict of interest, because these are policy updates and things like that they're keeping you informed to do it correctly, not in incentivizing, hey, just do this to get paid. It's completely different. And I think that's something on the pharma side that's been excellent to see, that they've made so many resources available. As Melanie and Angie, as you said, it's just keeping up with all of them and when they update, because the only thing worse than no information is wrong information. And we have one that we're sure of, yet it updated just a while ago. So keeping that and having some, hopefully that they're reaching out to you with those updates, but if not, that you have some schedule where you can reach out to them for those updates. But I did want to make that clarification from a compliance perspective. It's very different on procedure side than it is pharma side, as pharma is very, very different. So, but I like it. I like that a lot.
There you go, Jordan. And I'm all about cross-therapeutic, conversations, because we all have different backgrounds. And so, Linda, I specifically in the MS category, right? Area, I'm completely naive. I know nothing on that access piece. And I'm sure for the drugs that you work with, manufacturers are also reaching out to you as well. And being in a large hospital system, you have that. Any insights there? Any nice relationships you have with your reps?
With the hospital that I work for, it's a little bit more difficult, a little bit more, we don't want too much to do with the drug companies. You have to go out and reach for them yourself, outside of including the hospital. They don't want any kind of sway one way or the other. So I have to build my own relationships outside of the hospital themselves. It can be difficult when you don't have a large network of people to work with, but the MS is pretty large. They've got all kinds of like the MS Society. They've got groups and forums and things that they run. But it takes a lot of, so MS takes a lot of patient assistance and things away from the provider's office and the clinic, and they do it themselves. So I'm not really involved. I send them the information they need, and they take care of the patient.
Got it. Geraldine.
Yeah, so for MS, I think Ocrevus is probably the most expensive drug out there. Typically you see hospital charges of anywhere between 75 to 150,000 per dose, which is every 6 months. The thing I like about the FRMs too is they educate you to use the manufacturer's patient access programs, regardless of whether or not they're going to get patient assistance, because whether they need copay assistance or they need free drug or they don't need anything, if you enroll them in the patient access program, they will do that initial benefit investigation for you, including they're not going to get the prior authorization, but they're going to tell you whether a prior authorization is needed or not. So that is somewhat protective for you. And then they'll do the benefit investigation and tell you whether the patient is going to require assistance or not. So I just wanted to tack that on. But then I wanted to address the question that Fatima had about if there's a disconnect with contracted entities and the payer, such as AIM and Blue Cross Blue Shield. AIM states no prior auth needed or even gives an auth, and then and when the claim is processed, Blue Cross Blue Shield denies due to drug needing to go through specialty pharmacy. So when I worked in revenue integrity, I found this frequently where a payer will give a prior authorization approval, a number, anything, and you think it's solid and firm, and then they come back and they still deny it on the back end, saying that no prior authorization was given to us. And so in those cases, you do need to kick that back to the payer with the prior authorization number. It's always a good idea to get more contact info, you know, the person you spoke to, the time, the date, whatever, so that that follow-up rep in the billing office can kick it back to the payer and get paid for it. So it should not just stop at the denial. Then if they do try to push it through the pharmacy benefit, then what you need to do is on the front end, go back and say, we are a buy and bill facility only. We do not accept anything through the pharmacy benefit. We do not accept white bagged drugs, basically.
And Carolyn, question on that. So, you know, kind of tying into this theme of policy and restrictive policy, do you ever find that info, or do you use the formulary? Like, what tools do you use when you're starting this out to have that conversation? Because I know payers don't always see that, or the prior auth intake person doesn't see that. So can you kind of elaborate on that piece too?
So typically the payers, I find, in some cases, probably, I think Angie, this might apply to Angie, in some states, they require Medicaid to push their infusion drugs through the pharmacy benefit. There's no getting out of that. You know, if that's, you know, pretty much you're not going to win against Medicaid if that's the standing for the state. In other cases, it's not written in the policy to push back. I think it's encouraged to push back, and people don't think that they can push back. It's a lot more out-of-pocket cost for the patient if they have to get the drug through the pharmacy benefit. So I think, you know, what I encourage my prior auth staff to do is I give them a script and I say, we are a buy and bill facility only. We do not accept white bagging at our facility. This is a safety issue. We cannot verify the pedigree of the drug, meaning I can't verify where this drug originated from. I can't verify how it was stored or transported, versus I can verify that when it's delivered through the pharmacy, through the hospital pharmacy. And I would say 90% of the cases, we are then given a prior auth through the medical benefit as we want. So I think there's a lot of room to push back, and people just don't know that.
Yeah, so we do have to accept white bagging at my facility, and we had to make a policy and a process, and it is tedious. It's not just the whole integrity of the drug. It is tedious in a sense of all the hands that are involved to do this. You know, when the authorization team identifies Pennsylvania Medicaid does not allow medical benefits for any of the drugs, so it has to go through pharmacy. Once they identify them or another payer that might be mandating a specific drug, it's like a all hands in. The authorization team has to send a blast email to pharmacy. We do try to see if we can have everything originally filled through our hospital specialty pharmacy, because then I allow for clear bagging. If not, then, you know, our scheduling team has to wait 7 business days before the patient can be on the schedule, because we're trying to figure out, are we going to get the drug here? In Pennsylvania, the majority of patients who are going to remain in fee for service are undocumented. And so, you know, I would say 8 out of 10 do not speak English. So when they see an 888 number trying to get consent to deliver their medication to our infusion center versus their home, they're not answering the phone. So now my team has to get on the phone and do a 3-way call. And it's really 4-way, the interpreter, us, the patient, the pharmacy, to say, yes, it's okay to have it delivered here. Then we have to put our tracking hats on, because we're a big building. We're 7 floors here. And when UPS decides to deliver it to the 6th floor, and it was meant to be the 2nd floor, but we have a tracking number, we're looking for the package. So I don't think the payers realize, you know, just the impact on everybody that, you know, the whole not allowing the medical benefits to cover it causes as a cancer center. But in the same sense, we have to do what's best for the patient. So if that means our team now has to run around to the 6th floor and come back down to pharmacy and ask them to check, is this still a good medication or not? And, you know, we do what we have to for the patients.
But
Yeah.
you know, the other thing is that if it's white bagged, you cannot then charge, you can't mark up that drug and charge the payer again.
Mhm.
So you can only charge for the infusion fee. So
Yep, so-
ultimately, your
Yeah.
facility is going to lose money.
Yeah,
There's a reason why there's a drug markup. That drug markup is not just to make money off the drug. It's for, it pays for all of the processes surrounding the drug and all the people that touch the drug, the prior authorization process down to the pharmacy technician that mixes it. So we don't bill for those things. And so that's why we mark up the drug.
let's not forget that part. So that also
Yeah.
means added part of making sure that the drug gets marked as patient supplied. And if it doesn't, having a team to capture it so that the drug goes back to 1 cent, because you still got to bill it on the claim, because then if not, the payer is saying, what am I paying admin costs for
Right.
when I don't see a drug? So just the
And-
whole process.
And there's a lot on the private practice side where we have to also adjust how we bill our claims and things like that. But kind of one point that you guys are talking about, like, this is our rule, this is what we follow. How do you, when you come across something like this and you know it's a known issue, how do you champion this up to your admin staff and kind of push it up the chain? Because I know that we feel like we have loud voices and we make the difference. And I know it's a collaborative effort. So how do you accomplish that in your facilities?
I walk up to the admin office.
That's you, yeah. So for those of us that don't do that, Melanie, go ahead.
We, the wording that we use is so similar to what Geraldine and Angie said already, right? We use those exact phrases when justifying why we do not allow white bagging. And I will tell my team too, when they talk to payers, we tell them, say, okay, well, we do not allow white bagging. We need you to contact the patient and tell them that
Oh, that's
who
good.
does accept white bagging and who can treat them. You need to help your patient then figure this out. And if we had this recently where it was happening a lot with a payer, and it wasn't happening before as much. And then they were coming out, with a lot of the support medications now all have to be given not in the hospital. So instead of pushing it to my leadership, I took it to that payer's leadership. I went to the next provider meeting and I told them, I said, we're having all these issues. You're requiring white bagging and this is why we don't allow it. And I explained all the things that Geraldine said, right? And then I tell them also that we've had a lot of these specialty pharmacies send the drug too late or send the wrong dose. And then we told them to correct it and they send it too much. They send us too much. Now we have to mail some back and it's wasteful and all of these things. And so what happened is we told them all these reasons. We say, we are not going to allow it here. So for this whole population, we need you to figure out what we need to tell your patients when it's a drug that you're going to enforce this so we can tell them where to go. And what ended up happening on that, and we're in the process of it right now, is with that payer, they're actually allowing us to apply as a specialty pharmacy so that it no longer is requiring us to get the drugs sent from a specialty pharmacy. And who would have even known that that was an option? I didn't know that. It was just from going to that provider meeting and being there with all the provider reps and our contracting people hearing it, and not having anything left to argue and being like, okay, well then what is a way then that we can get through this so that we can not disappoint all of our patients and not delay their care. And so I just learned that they're actually allowing us, and this is a payer that all of us deal with, and they're saying that our hospital, our health system can apply to be a specialty pharmacy within their system, also that designation, which will then not require it.
That's interesting. And so you brought up a good point. We're getting some kind of feed in the chat from it. So I kind of want to bring that kind of topic up, is the contracting side of things, right? Where to get involved. And one of the terms that someone threw in there is managed care or managed services. And I think a lot of these payers recently have changed how they handle this portion of it. A large national payer we all work with got rid of their provider relations reps right? You used to have a dedicated person that if you had a problem with a policy, with a claim, with an authorization case, you could call and take that up. And I think managed care is an important piece of the puzzle, as those of us that are in medication access, really learn and understand about. I know that took me a couple of years to get under my belt, but it does exist. It is a department. It is a great experience to have. I'm not super knowledgeable in contracting, building side. I'm on the fighting side of it. So I think that's a great point to bring up. And I want to make sure as we get closer to the next hour here, we've gotten some really great questions in here. We've addressed some, and I want to make sure that we answer these because this is what we're here for today. Lots of comments about health systems and white bagging, one of my favorite topics to talk about. But a question, besides medical necessity, for medical, are you checking site of care PBM restrictions? We haven't really talked too much about PBM restrictions, and then biosimilar product preferences, especially if no auth required. Geraldine, that was lightning fast.
Y'all are having a blast there, man. I feel like if you're going to throw in biosimilars and PBMs, let's throw in 340B. Let's have a ball here, guys.
Payer
Okay,
policies, guys.
so-
Payer policies.
So typically there should not be a PBM involved on the medical benefit side. That is traditionally reserved for the pharmacy benefit side. So the question was, am I checking PBM restrictions for site of care? No. However, as far as biosimilars, biosimilars is probably a whole different topic because every payer is going to require a different biosimilar. And those are kind of hard to memorize as well. But I think what I find is most of the time when the prior auth staff calls for the prior auth and they try to get it for something, let's just say Remicade, they're going to be met with, well, the patient has to utilize Inflectra or has to utilize Renflexis, and then they'll only allow the prior auth for that. But then you have to go back and get the order for that biosimilar. You can't treat the patient with the order for Remicade and then use the biosimilar product because you're not going to get paid that way. But there's other ways to push back on site of care denials as well. I would say patient safety is a big one. So at the standalone infusion centers, they don't have access to emergency care services right there. And so even though some of these drugs, the payer doesn't consider them to have a high incidence of infusion related reactions, it's not true. I mean, I won't tell you what happens when somebody has a bad iron infusion reaction, but it's not pleasant. And it tends to clear the room. I'll just say that. So, they can be really severe and they don't have the medications available that they need to treat the patient in that kind of emergency situation. Also, the patients can be a hard stick, and sometimes you need ultrasound to find that vein. And so if they need additional resources to get peripheral access, that's a way to push back on the payer. If the patient has some sort of comorbidity that puts them at risk for getting treated somewhere where they don't have that level of care, that's a way to push back on the payer. So, I think nobody loves to argue more than me. I know that. But I have found every way.
I second that. Just kidding.
I find a way to push back on the payer any way I can because I simply want to keep that continuity of care with the patient at the infusion center. The patient hates when they're sourced out to a different infusion center after they've been receiving their infusion with us for 3 years. They're devastated. They're terrified. And so ultimately it is a patient care issue. So that's why I fight back.
I think we see this as going to be difficult in moving forward too. Geraldine, Angie, you can probably speak to this. I know Penn has a program up there by you, but like home side of care home infusion is becoming a very, very big deal now. Now, listen, we can argue it 6 ways to Sunday. I've had to get into cases where it's temperature of the drug. Is it a sterile environment where we're doing it? And we're not talking just chemo drugs. Maybe it's antibiotics, maybe. And yes, there's probably a time and a place for it, but is there consistent nursing available side of, an adverse event or reaction? You've given the drug 2 or 3 times, there's never been a problem, but on number 4 or 5, there is a problem, and it's site of service at home. But I mean, that's a big push right now, is to do a lot of home infusion and home drug therapy. So Angie, are y'all seeing that up there with you? I know there's several programs up there by you that have created this for site of care home.
Yeah, I mean, so right now, all we really see is just more the site of service that we're still able to tag out on the office side. So since we carved out that space, we're okay. We're not at a point where before, when we had, even before, if there was, onesie, twosies, used to be IVIG. That was the biggest one. First time you get approved to be in the infusion center, and then it had to be either home infusion or office space. We hadn't carved out space yet, but at that time, 2 of our infusion centers were office space. So we had to sort of have the patient go there, which still was an inconvenience, because it wasn't like it was the one that, like Geraldine said, it wasn't the one, their home base, so to speak. So now we're having them, go to a different location, but we haven't had that issue right now. I see a lot of site of service more for those non-oncology infusions, for the Remicades and whatnot. But, so far for us, even though some of the payers say it, like we've had some of the major payers say Keytruda had to be off the site of service drug.
That's nuts.
Exactly. But it's so crazy because that same payer that's given that information to our revenue integrity department is the same payer that continues to authorize it on the hospital side. So I had to go back and forth with my revenue integrity department because they wanted to sort of make this rule. And I'm like, whoa, until the payer actually tells us on the phone and that we can't get the authorization, like, why would we, one, take lesser money because you got to speak revenue integrity to revenue integrity, but two, like, why would we do that? Like, it didn't make any sense. So, I tell them that we have to try. So even with authorizations, I think it goes back to the whole step edit thing, right? If the if the provider puts whatever they want first, as long as that documentation supports it, still try that authorization request. Same thing for us. Even though revenue integrity was giving us this list, including Keytruda, which I still can't get over, saying that it had to be site of service, we told our authorization team, no, we're still going to go through hospital outpatient first, and let's see if we start getting, and it's been about 2 years from when they made that list for us. And out of those 5 payers that they said were site of service for oncology drugs, only one of those payers are holding us to it. And those were an injection, so we were used to it.
And what place could be least safe than somebody's home? Is that nurse wheeling in a crash cart to every house? I highly doubt it. And, to speak to Jordan's comment about sterile environment, your neighbors that have 13 cats, like these are not sterile environments that they're infusing these places. I know I wouldn't even say my house was sterile enough to infuse me there. So I'm the first one to say it.
Geraldine, my question to you, and it actually comes from the chat. So in these cases, when you're pushing back, right, and this is kind of a great case for everyone on here, in your facility, right, Jalen, I know you will pick up the phone and do a peer-to-peer, but what's happening with the peer-to-peer? Like, are you defaulting to that? Or are we using appeal letters? What's the preference?
Well, they default, so you almost have to do a peer-to-peer. But what ends up happening is that peer-to-peer falls through due to a lack of communication. So it may not even reach the physician that they need to do a peer-to-peer. And so then the drug just gets denied and the patient is put on, not even close to what the, treatment option that the physician wants should be. After you exhaust the peer-to-peer, it's a lot harder. You can write an appeal letter. If you write an appeal letter on the front end, you are going to wait at least 30 days for a response. So you're going to be waiting 30 days to start a patient on treatment. It's just not realistic. So the route we typically go if a provider really wants to start a patient on a particular therapy is we go the patient assistance route instead. And if you get a denial, most manufacturers will go ahead and grant you patient assistance or free drug in those cases.
And so the peer-to-peer, right, just to kind of keep everyone on the same page, depending on where you are, practice, facility, what it be, different people can do peer-to-peers. I always ask if I can do a nurse peer-to-peer, and, pharmacists and, obviously our physicians. So there are a multitude of stakeholders in the process that can.
Pharmacists are becoming more and more popular to utilize for the peer-to-peer because we have a tendency to actually read the notes and the H&P when we're, entering the medications. So we know the patient after seeing them so many times.
Correct. So we've got about 5 minutes left till we've had an hour of everyone's wonderful time. And I want to get into some questions that we've gotten. But again, I want to call out a couple key things here. First of all, thank you again to Daiichi Sankyo DSI for sponsoring this webinar, as well as Prescribe Plus. Thank you to our panelists for joining. I'm sure we could have just turned this on for 24 hours and kept going. It probably would be a very lively discussion. But one question that we got, can someone from our group please clarify what a PBM requirement is or what that means?
Well,
Anybody?
The PBM is a pharmacy benefit manager, and they kind of stand in between the insurance company and the pharmacy. So ultimately, the PBM is kind of, I don't want to say an extension of the payer, but the PBM is trying to both negotiate the drug at the cheapest cost on behalf of the insurance company. So they have a vested interest in denying your costliest therapies. So, maybe, let's see, what would be a good example? Like Aetna and CVS Caremark, maybe. Like Aetna is the payer, CVS Caremark is the PBM. So when you go to do your prior authorization on the pharmacy benefit side, you're applying to CVS Caremark for that authorization and not Aetna. Whereas on the medical side, you would be applying to Aetna and not CVS Caremark.
And then one question we got by show of hands, I don't think we have to address this individually. Who uses Cover My Meds for prior authorizations in some way, shape, or form? I know I do.
Yeah, we do on the pharmacy benefit side.
Okay, Linda, see, there we go. There we go. Okay, so another one that we got in here, this is on patient assistance programs. Do you find that most patient assistance programs want to see 2 denials before consideration? In my world, sometimes that is before we get free drug. That is the limited supply programs where they carry it over for a time being. Angie, what about you or Melanie?
So I think it really depends on the manufacturer. Honestly, most of the infusion drugs, I don't need to get 2 denials. I need 1 denial, and I need a valid denial. I've had times where my authorization team sends me because the doctor didn't do the peer-to-peer, and I'm like, not valid. But I see a lot that do allow me, but that's more the infusion. I feel like the oral drugs are the ones who usually want that second layer of a.
Well, I think it depends on if it's a front end denial with the prior auth staff or it's a back end denial. If it's a back end denial, like let's say for Medicare, you get the denial because it doesn't require prior authorization. So you get the denial, then you go ahead and you do a first level appeal. And then there's 5 levels of appeals for Medicare, but you do a first level appeal. And again, it's denied at the first level. Some manufacturers will only grant you free drug after a second level denial. So that might be 3 denials. Like Angie said, it's going to be manufacturer specific. On the front end, you just typically need 1 denial. And yes, it has to go through a peer-to-peer if that's a requirement. So some payers don't require a peer-to-peer. They're just going to say, nope, it's denied, and not even grant you the option of the peer-to-peer. At that point, you get the denial letter, and I submit that with the application for the patient assistance program. And then typically you're awarded patient assistance at that point.
Yeah, I think
That's
there's only
usually
a
what we find
couple.
too. It's the first, usually it's 1 denial for auth, and there are some manufacturers, I won't name them, but I can think of 2 right now at the top of my head that if it's the claim, then they do require 2 denials. There's actually one manufacturer that requires 2 denials, and they have to be a part of those. They have to be able to assist us on what wording to put in the letter when it's the claim level denial. And a lot of these, though, they do require still that you have been signed up or they have done the manufacturer app prior to their date of service. So high cost drugs, we make a point too to have those apps done as a cover our butt later. You know, if it's prior auth, it is always easier at prior auth time to get it. It's not two denials usually at that point, it's later.
And I think it depends too, just for clarification purposes, whether it's drug assistance or again, back to those kind of bridge sustain programs. Because is it for under or uninsured, or is it for someone who just has denials, right? So a lot of manufacturers have two different programs that are out there that you can direct that patient to. But yeah, to everyone's point, that is absolutely correct. Coming up on time, I round robin one last time. If you have a short key takeaway, you would give anyone who's working in this kind of restrictive payer world, what would that be? Jordan Johnson.
Better know somebody, phone a friend. I mean, there's no way you can keep up with everything. So you need to have your lockdown core group of like 5 or 6 people that you can go to.
Yep. Angie.
I think that's the biggest thing. It's making sure you keep a network, you know, and I saw some of the comments, let those full reimbursement managers in. It's so, you know, definitely makes it a little easier for your staff.
Linda.
Looking for, or search should answer for you.
Yeah. Melanie.
Real quick, that white bagging policy I sent out is a few years old, but it is what we use to help us figure out our wording to fight back on white bagging. But as far as step therapies, I just want to say there's all these tools, right, with the going to the manufacturer for help, going to the provider for peer-to-peer, all these things. But I think the first thing, though, is a lot of times if you did review the records and really reviewed the policy or talk to the doctor, if maybe it's just not in your documentation, but they do have a history of this, or because of their labs, or because they're pregnant, or because of these things, that you'll find that you don't actually have to make them go through peer-to-peer, go through these other levels. Like it's usually, they would qualify, and it just takes some researching first on your part, and you could usually avoid a lot of these.
Yep. Geraldine.
I know keeping it short, that comment was directed at me.
Yes, ma'am.
Anyway, so my takeaway would be, for the love of God, communicate with your staff, you know, communicate amongst each other. You're usually located in the same section of the facility. Walk up to the admin office and talk to your prior auth staff. And number 2 would be push back. Like, you do have options when you think you don't have options. Don't just take the payer's first, you know, response. So, and that does take a little, you know, it takes an extra step or an extra layer of work, but it's worth it.
And then I will throw out, because no one else said it, you can always turn to organizations such as NMAPA. We have resources and tools there. And as a sustaining partner for the Healthcare Advocate Summit, which we will be at later this year, back to what Jordan was saying, find your network, right? So Healthcare Advocate Summit is September 7th through the 9th in New Orleans. And this is a place where everyone you see on this webinar today will be. We will all love to continue the conversation. There's never enough time when you have a group of passionate advocates like this. So I am, again, beyond thankful to our sponsors, to these panelists. You guys, I am glad to call you both colleagues and friends at this point. And Jordan Johnson, who apparently is my brother, but you know, everyone gets that confused sometimes. It's fine. So thank you all for spending the last hour with us. This will be recorded and we will distribute this out. You can connect with us via LinkedIn, via the NMAPA website, as well. I think my email is in the chat a few times. So we look forward to hearing from you, and thank you again for your time today, guys.
Thank you guys.
Thanks.
Thank you, everyone.